This is a Chronicle podcast, bringing you ideas in the service of medicine.
From the Chronicle podcast system, this is a Skin Spectrum podcast. It's Yadav on Acne, with Dr. Geeta Yadav. Based on recent publications from the clinical literature, Dr. Yadav provides brief synopses of recent significant clinical developments in acne research, and provides her observations and comments to accompany each report. In each episode, Dr. Yadav will answer questions and offer her expert observations and anecdotes on treating this disease. If you have a question for Dr. Yadav, or want to be in touch at any time, just send an email to yadav@chronicle.org. That's YADAV@chronicle.org. And, if you attach a voice clip, we might even use your question on an upcoming episode. Support for this podcast comes from Cipher Pharmaceuticals. Cipher is a specialty pharmaceutical company with a robust and diversified portfolio of commercial and early to late stage products. Cipher currently markets dermatology products directly in Canada and indirectly through partners in Canada, the US, and South America. Visit them at cipherpharma.com. And now, here's John Evans.
Thanks, Leona. Welcome to the first episode of Season 2 of the Yadav on Acne podcast with Dr. Geeta Yadav. I'm John Evans, Senior Editor at the Chronicle of Skin and Allergy. In this episode, Dr. Yadav will discuss research on managing moderate to severe acne using isotretinoin. Our first study in the June issue of Digital Health and Dermatology compares the outcomes of managing patients on isotretinoin through teledermatology or in-person care. The authors found similarly favorable therapeutic responses and adverse effect rates between the two approaches. Welcome, Dr. Yadav. What are your thoughts on remote management of patients on isotretinoin, and how might this impact patients in underserviced communities?
Thank you so much, John, for having me back on this show. I really enjoyed reading this paper because it did remind me of my own experience of treating patients with moderate to severe acne during the pandemic. So I think it's been pretty well established that teledermatology is a great modality to improve access to care and to reduce costs, especially in a country as large as Canada. These things are very important because we do have a number of patients that live in rural and remote areas that can be difficult to access and where specialists may not live. So in this study, about 32 patients were examined who were either seen in person or through asynchronous telederm visits and completed an isotretinoin protocol. And it turns out that adverse events were comparable between the two groups. That includes everything from pregnancy to cholesterol to transaminitis and arthralgias. And so that teledermatology-based treatment of acne with isotretinoin worked just as well as in-person treatment according to this small study. Just sort of shows that this is a great modality that we may be able to leverage to treat a certain subsection of our patients, and that the outcomes are equivalent to seeing people in person.
For our next question, we look back at research by Las Vegas-based dermatologist Dr. James Q. Del Rosso and his colleagues on long-term relapse rates in patients taking low-dose isotretinoin without food. They found comparable relapse rates over 2 years compared with patients taking non-low-dose isotretinoin with high-fat meals. Dr. Yadav, what factors do you weigh in choosing an isotretinoin product for your patient to ensure the best outcomes?
So, John, this one's a really interesting study, in part because it's done by such a well-respected group of dermatologists in the US. As you know, James Del Rosso runs the fall and winter clinical meetings in the US every year, which are some of the biggest dermatologic meetings in the US. And so they were kind of looking at the long-term relapse rates following low-dose isotretinoin taken without food in patients with severe recalcitrant acne. Just for our listeners, low-dose isotretinoin is marked under the name Epuris, which is also a formulation that has higher potential bioavailability in patients. And I've already noticed in my own practice a huge difference in how patients are responding to this medication, even though it's a drug that we've had in our toolkit for quite a while. The idea, being that theoretically if you have higher bioavailability, if you have a better sort of pharmacokinetic profile, then it's possible that you absorb more of that vitamin A isotretinoin medication, and therefore you have a higher chance of getting sort of a quote unquote cure at the end of completing a standardized treatment protocol. And certainly in this study, what they did find in the post-treatment period, that patients who were treated with sort of traditional isotretinoin had relapse rates closer to about 17%, whereas those treated with low-dose isotretinoin only had a relapse rates of around 4%. And so, this kind of prospective open study sort of showed that the relapse rates could be different when compared to traditional isotretinoin. And so, going back to your question around how do I choose an oral medication for my moderate to severe acne patients, I would say certainly data around bioavailability, the pharmacokinetics of the medication, how it's delivered is an important aspect. I think also ease of use. On the one hand, we have these amazing novel kind of, I want to say formulation, but it's really like, how isotretinoin is put together to be well absorbed for isotretinoin. But on the other hand, some of these tablets can actually be a little bit larger. So depending on their coatings and such. So you might have a patient that requires a tablet to be crushed or requires a tablet to be small. And so I really do think that looking at the entire picture of patient needs is something that I like to consider when I'm treating my moderate to severe acne patients.
Our last study today is an examination of how the C. acnes strains in the follicular microbiome shift due to isotretinoin treatment response. In this paper in July's Experimental Dermatology, the authors note that they didn't see the same changes in the microbiome in patients who failed to respond to isotretinoin, and suggest that finding other ways to cause these shifts in microbiome could aid in the future of acne treatment. Dr. Yadav, what are your thoughts on managing the skin and follicular microbiome to support existing acne treatments?
So you're right, John. This has been such an area of interest for the last 5 to 10 years, but I haven't seen the clinical correlation yet in the same way that this paper describes, which I think is sort of a really neat translation of some of what we've come to understand theoretically into what we can do practically for our patients. So oral isotretinoin is one of the few medications that can kind of target all 4 of the, pathogenic areas involved in acne formation. And specifically, Cutibacterium acnes is the bacterial agent as part of our microbiome that seems to be driving part of the pathogenesis. And what this paper sort of shows is they didn't just look at the microbiome or the microflora of the skin at a superficial level. It was also examined deep in the polysebaceous units to kind of see how isotretinoin impacted the skin's microbiome and what those differences would translate into in patients who achieve successful isotretinoin therapy after 20 weeks. And what the authors found is that actually after 20 weeks of treatment, that patients who had been treated with isotretinoin and had successful outcomes actually had a reduction in their Cutibacterium acnes flora, or I should say their Cutibacterium acnes burden, but the other bacteria on the skin actually remained the same. And what's more is that they did also notice increasing diversity in that Cutibacterium acnes, and that was actually helpful in creating a more kind of, stable skin environment. And this means even after isotretinoin therapy was completed, 6 months, post-treatment, a number of months out. So I think that this paper really does kind of bring home that acknowledgement that, successful treatment response to isotretinoin can really be correlated to the reshaping of the Cutibacterium acnes profile on the skin. So to get another perspective on today's topic, we reached out to Dr. Sam Hanna. He's a Toronto-based dermatologist and medical director of dermatology on Bloor. He's also the president of the Toronto Dermatologic Society. Dr. Hanna, what's your top advice for working with isotretinoin to treat patients with moderate to severe acne?
Everybody certainly every dermatologist, everybody who treats acne with systemic medicines and has been doing that for a while knows that isotretinoin obviously has a very special place in our therapeutic regimen. And, I'm old enough to remember when we were using antibiotics very differently than we are now for sort of longer term suppression. And it turned out that that was a bad idea for a number of reasons. And what has filled that gap for a lot of my patients is really the earlier reliance on isotretinoin. It is an area where I think it's really the place where dermatologists can really shine as the experts in skincare and skin disease. It's not an easy thing. I think, we've all seen scenarios where somebody who isn't a usual isotretinoin prescriber sort of tries to do it, looks it up, and there are some real finesse points about it. I think the biggest thing about using isotretinoin is it's one of the scenarios clinically where I just have to accept and willingly give that this is something that, at least in the initial visit, in the discussion, is going to take time. And I think we all know that dermatology can be sort of a quick hit kind of specialty, but this is not that visit where we're really discussing isotretinoin as an option for patients. That's not one of those. That's one that I sit down and we spend the time going through some things, answering questions. The reason that's super important is because it's very rare that I don't have that conversation where patients aren't coming into that conversation with preconceived notions. My friend did this, my cousin did this, my sister did this. This is what I'm worried about. This is what the internet says. And it's really on us. Isotretinoin is really one of those derm drugs. It's our resource to steward and to deploy effectively and safely. And there are a number of things to talk about, from, obviously pregnancy prevention concerns to day-to-day side effect concerns. And it really does pay dividends to spend a little bit of extra time or a lot of extra time in that initial visit, using that time to sort of allay some of those fears, lay out what the expectations are during the course, what my plan is, what patients should expect. What's my expectation and plan after they're done? It's not common anymore that I'll tell, people, oh, once we do this, you're done forever. I will tell them about some plans afterwards. I like to demystify some of the concerns. It's one of the places where I'll talk about sort of data and talk about, say, mood change and this correlation versus causation idea. Super important to give patients that, because if you don't give it to them and they find it on their own, it always seems like you're sort of keeping something from them and you're trying to trick them into something. And really, what I tell patients all the time is this is what dermatologists, this is how we treat people we like and we care about. And it's part of my very routine care for acne that is more than mild, and certainly even mild where it's persistent despite, say, topical therapies or short course antibiotics. I think, having tools for patients, we have handouts, we talk about skincare, we talk about what to avoid, that kind of thing. That's also part of becoming sort of an isotretinoin expert, which I think as a dermatologist, I feel it's my duty to be. So I think for me, it's the time, it's the preparation, and it's the giving opportunity for patients to ask their questions, have their questions answered, and to be able to reach you if they have issues.
We turn now to a segment where we discuss acne myths and trends that are prevalent on social media. The first comes from Pamesco on Reddit. This person says that skin cycling, alternating a 2-day program of acne care with 2 days of rest, resulted in their acne worsening and her previous skincare routine becoming ineffective. Dr. Yadav, what are your thoughts on the practice of skin cycling in acne care?
So, John, skin cycling has become quite a trendy concept, and it's been promoted by a number of dermatologists in the US. And I do like the idea. I think it's sort of a clean word to use to describe something that we often recommend to our patients, which is to introduce certain very active products and ingredients to the skincare regimen in a slow kind of way. And it may be that for this individual, skin cycling meant not using their acne products frequently enough, and therefore truly not getting enough of a benefit. What I think is a little bit of a clearer advice for patients who are actively trying to treat a problem would be to say, well, introduce your active ingredients like a topical retinoid into your skincare regimen slowly but surely, trying to work yourself up to an everyday kind of thing. Skin cycling at a high level, I think, is probably better served for people that are not tackling a specific problem, but who are maybe more interested in overall anti-aging and skincare kind of benefits. I think if a patient is struggling with acne and they're finding their over-the-counter routine isn't working, or that their previous routine was working better, then definitely they should stick with that, so long as it's not causing too much irritation and that they're tolerating the products well and they're getting the result that they want.
Armin Adamjan, also known as Creative Explained on TikTok, suggests making a paste of baking soda, honey, and apple cider vinegar as an overnight topical spot treatment for acne. What would you say to that?
Well, interestingly, when you look at those different ingredients, they do have some properties that are meant to be anti-inflammatory, exfoliative, some wound healing properties in honey. Apple cider vinegar is the one that comes up most often amongst dermatologists, and I think we are the most cynical about that one. But actually, you'll find skincare ingredients over the counter that do contain this sort of active ingredients. It does have some claims around being able to balance the skin's pH and cause some exfoliation along with lightening hyperpigmentation, which is something that patients with acne can struggle from. I think what's hard is to really kind of make the claim that somehow these individual ingredients sort of smashed together, leaving it on the skin overnight is necessarily a good at-home remedy for acne. I mean, first of all, some of these products can be quite irritating if left on the skin. They can also, I think, vary in terms of their concentration, in terms of what you buy and how you're using it. And so I guess I would sort of say there are safer, sort of more tried, tested, and true alternatives that are available either over the counter or, again, if you see a board-certified dermatologist, get a prescription, then this sort of pace. So I wouldn't be as inclined to use this. I think there are better options out there, but I see the logic behind why Creative Explained wanted to try this.
Dr. Yadav, earlier this year, you were quoted on Yahoo News talking about a hack posted on TikTok by user BreeBaby for using anti-inflammatory eye drops on acne lesions. What can you tell us about this hack?
So these anti-inflammatory eye drops are also brimonidine, which we know can reduce the appearance of blood vessels on the skin. The issues are that, first of all, that's only going to be temporary. Second of all, there is a risk of rebound in terms of the amount of erythema seen on the lesions. Third of all, it can actually make that area of the skin look vastly different than other areas of the skin, so the camouflage may not be as expected. And lastly, a patient can develop a contact dermatitis from repeated application of this topical to the skin. So I, again, would caution on this. It doesn't actually treat the underlying issue. My advice to patients would be to actually use something that's going to actually treat the underlying problem rather than this solution, which is a little bit more of a camouflage and can have unintended consequences.
Thank you, Dr. Yadav. Listeners, if you have comments or questions for Dr. Yadav, send them over. Send an email to health@chronicle.org. Add a voice clip attachment to your question, and you might appear in a future episode of this podcast. If you enjoyed this podcast, please share it with your colleagues. You can subscribe at Apple iTunes, Google Podcasts, Stitcher, or wherever you get your podcasts. This podcast is produced in cooperation with Cipher Pharmaceuticals Inc. I'm John Evans, Senior Editor at Chronicle Companies. Your host has been Dr. Geeta Yadav, Founder and Director of Facet Dermatology in Toronto and a General, Medical, and Cosmetic Dermatologist. We'll talk again next time.